Hello everyone. Okay, so we have started the OSPE preparation for surgery subject. We have discussed our radiological examinations. Now we will study the clinical examination and short cases. How to do the short cases in surgery exams. We have the following contents, that is inguinal scrotal area and hernia, umbilical, para-umbilical, epigastric or incisional hernia, lumps or swellings, examination of breast, examination of neck swelling, salivary glands, examination of ulcers, examination of varicose veins, examination of peripheral vessels, examination of abdomen, examination of lymph nodes, and examination of peripheral nerves. These are the topics which we have to prepare for the short case portion of surgical examination. So let's start from the general introduction. In clinical examination and short cases, during final professional examination, the clinical examination is divided into short cases and long cases. The basic purpose of short case is to evaluate the clinical skill of the student and to check her ability to make spot diagnosis. A specific task is allocated to the student. For example, you are asked to examine the neck of the patient. While in long case, one patient is allocated to the student and ample amount of time is provided. During this, the student is allowed to take complete history, perform general physical and systemic examination. It can also be asked to write the history or narrate it in her own words. Examiner then discuss with you about the history and your clinical examination. You are also asked about relevant investigations, diagnosis, and differential diagnosis is also discussed. In this chapter, we will discuss the important short cases and history taking. Complete general physical and systemic examination will be discussed in next chapter. Short cases are the most difficult but most rewarding portion of the exam as it has got higher weight of total marks. In short case, you have to make a quick diagnosis within limited time and in the same time you have to follow a sequence. If a short clinical examination put a bad impression on examiner, it must be remembered that each step of clinical examination carries its own weightage, so you must be very meticulous in the steps of examination. Now, what are the steps of short case or examination? First of all, always approach the patient from right side. Wait for the command from examiner before starting your examination. Then greet the patient, say hello, introduce yourself, I am Dr. X. Explain the patient what you want to do and take the consent. That is, I want to examine your inguinal area to diagnose your disease and it will not disturb you much. Would you agree, please? Proper exposure but decent exposure is required nowadays. If your patient is female, ask for female attendant or nurse while examining her. After exposing the area to be examined, proper coverage with screen or curtain should be observed to ensure privacy. Necessary relevant questions should be asked from the patient during examination. For example, during examination of thyroid, you may ask weight loss or weight gain, appetite, sleep, and palpitations to rule out hypo or hyperthyroidism. You are allowed to ask 4 to 5 relevant questions in each short case. The sequence of examination, that is inspection, palpation, percussion, and auscultation, and relevant examination must be followed. During short case, you must examine the area whose command has been given to you by the examiner, but at the same time you must not forget the relevant examination. For example, during examination of scrotal hernia, you examine the inguinal area at same time must examine urethra, abdomen, chest for chronic cough and digital rectal examination, which may be the causative factor for hernia formation. The aim of examining the patient to reach the diagnosis must not be forgotten. At the end of your examination, cover the patient and pay thanks to him or her. After the completion of all this, you are asked to describe your case. Your description must be comprehensive, to the point, and mature and with full confidence. At the end of your description, you will be asked some viva questions like what is your diagnosis? What is basis of your diagnosis? And then any question to check your core knowledge. Now we will discuss important short cases one by one in the sequence which has been described. We will start from inguinal area pertaining to groin. Before starting the examination of inguinoscrotal area, I want to explain the anatomy of inguinal area and brief overview of the condition pertaining to this area. Anatomy of inguinal area. Inguinal area contains of inguinal triangle. Inguinal triangle is the region of abdominal wall also known as Hazelbeck's triangle, through which direct inguinal area protrudes. Its boundaries are medial border, superolateral border, and inferior border. On medial border, lateral margin of the rectus sheet, also called linea simulinaris, is present. On superior lateral border, inferior epigastric vessels are present, and on inferior border, inguinal ligament, sometimes referred as Puppert's ligaments, are present. These are the borders. This is rectus sheath, which is medial border. This is inferior epigastric artery, which is superior lateral border, and this is inguinal ligament, which is inferior border. These are the borders of Hazelbeck's triangle. This is Hazelbeck's triangle or inguinal triangle. Now, what are the boundaries of inguinal canal? What is inguinal canal? Inguinal canal is 3.75 centimeter long in adults and extends from deep inguinal ring to superficial inguinal ring, directing downward, forward, and medially. Deep inguinal ring, it is an oval opening in fascia transversalis situated 1.2 cm above the midpoint of inguinal ligament and immediately lateral to the stem of inferior epigastric artery. It should be remembered that there is a huge difference between midpoint of inguinal ligament and mid-inguinal ligament. Midpoint of inguinal ligament is situated between anterior superior iliac spine and pubic tubercle, whereas mid-inguinal point is located midway between the anterior superior iliac spine and pubic symphysis. Femoral artery is located at mid-inguinal point. Superficial inguinal ring. Triangular gap in external oblique of aneurysm is superficial inguinal ring. This is mid-inguinal point and this is the midpoint of inguinal ligament. The midpoint of inguinal ligament is located between the pubic tubercle and anterior superior iliac spine, and the mid-inguinal point is located between the anterior superior iliac spine. This is the femoral artery, this is mid-inguinal point, and this is pubic symphysis. Okay. Now, figure demonstrating relations and boundaries of inguinal canal are given as anterior superior iliac spine, pubic symphysis, deep inguinal ring, superficial inguinal ring, and inguinal canal. This is a figure in which all the parts are present. This one is anterior superior iliac spine. This one is pubic symphysis. This one is deep inguinal ring. This one is superficial inguinal ring. This one is inguinal canal. Okay. In males, it allows structures to pass to and from testes to abdomen, spermatic cord, while in females, it allows the round ligament of the uterus to pass from uterus to the labium majora. The contents of spermatic cord are best remembered in three arteries, three nerves, three other structures. The three arteries are testicular artery, cremasteric artery, and artery to the vasa deferences. The three nerves are ilioinguinal nerve, cremasteric or genital branch of genitofemoral nerve, and Titan sympathetic nerve. The three other structures are the vasa deferentia, the pampiniform venous plexus, and draining lymphatics. It is a common frustration among medical students that they are unable to observe these rings, deep inguinal and superficial inguinal, as openings. To understand this, one must consider figures seen inside the gloves with the absence of opening for fingers. When glove is viewed from inside, same is true for deep and superficial ring. Fascia transversalis is attached to the margins of deep inguinal ring, and a deep ring it elongates around the cord like glove on a finger, where it is called internal spermatic fascia. External oblique aponeurosis is attached around the margin of superficial inguinal ring, and its superficial ring it elongates around the cord as external spermatic fascia, as seen in the figure below. This is the figure. This is the inferior epigastric vessels, deep inguinal ring, extraperitoneal fascia, parietal peritoneum, conjoined tendon, peritoneal bulge, superficial inguinal ring, and testes, deep inguinal ring, and superficial inguinal ring. Now, when the testes descend from the abdomen into the scrotum through the inguinal canal, it drags the parietal peritoneum along with it, which is called processus vaginalis. The proximal part obliterates while distal part persists around the testis as tunica, parietal layer, tunica albuginea, and inner layer tunica vaginalis. If the proximal portion of processus vaginalis fails to obliterate, then peritoneal fluid or loops of bowel can bulge through it, which is known as infantile hydrocele or indirect inguinal hernia, respectively. The layer of peritoneum through which fluid hydrocele or bowel loops hernia come down to the scrotal area is called hernial sac. Now, what is the inguinal hernia? Inguinal hernia can be direct or indirect. Indirect hernia is the one in which loops of bowel or amentum passes through persistence of patent processes vaginalis, deep inguinal ring, inguinal canal, and then through superficial inguinal ring to reach into the scrotum. Direct inguinal hernia bulges through the inguinal triangle into the inguinal canal and then through superficial inguinal ring into the scrotum. Look carefully at the diagram given below and try to differentiate between direct and indirect. This is the direct inguinal hernia and this is the indirect inguinal hernia. This is ductus deferentis. These are herniating bowel passes lateral to inferior epigastric vessels to enter deep inguinal ring. Loop of bowel inside cord and hernial sac within spermatic cord. These are the other organs: lateral umbilical fold, inguinal triangle, medial umbilical fold, and medium umbilical fold. This is the peritoneum, transversalis fascia, transversalis abdominis muscle. This is the external oblique. This is the external oblique muscle. Testicular vessels entering the spermatic cord. This is ductus deferentis. This is deep inguinal ring. Herniating bowel passes medial to inferior epigastric vessels, pushing through peritoneum and transversalis fascia and inguinal triangle to enter inguinal canal. Femoral artery and vein, superficial inguinal ring, hernial sac, and spermatic cord. Now, indirect inguinal hernia results from persistent patency of processus vaginalis. It is most common in children and young adults. Hernial sac enters the inguinal canal through the deep inguinal ring and lateral to the inferior epigastric vessels. Hernial sac lies within the spermatic cord. Direct inguinal hernia is more common in old age with weak abdominal muscles and less common. Hernial sac bulges forward through posterior wall of inguinal canal medial to inferior epigastric vessels. Hernial sac runs parallel to the spermatic cord. Now, femoral hernia. Femoral hernia is a protrusion of abdominal viscera down through the femoral canal. What is hydrocele? As we have already discussed that during intrauterine life, when retroperitoneal testis descends down from abdomen to scrotum, it drags a fold of peritoneum along with it, which is called processus vaginalis, the proximal portion of which obliterates and distal portion persists along testes, forming the tunica vaginalis. The tunica vaginalis is potential space of fluid can accumulate in it, which is called hydrocele. Depending upon the site or extent of obliteration of processus vaginalis, there are four types of hydrocele: congenital hydrocele, infantile hydrocele, incested hydrocele of cord, and vaginal hydrocele. Congenital hydrocele processus vaginalis fails to obliterate and fluid from peritoneal cavity can freely move to scrotum. In most of the cases, it is associated with indirect inguinal hernia, reducible on laying position, and shows fluctuation and transillumination. Infantile hydrocele in this process vaginalis obliterates at level of deep inguinal ring while it persists distal to it. Fluid accumulates in it. It is not reducible but shows fluctuations and transillumination. Incested hydrocele, proximal and distal portion of processus vaginalis gets obliterated and central portion persists, fluid accumulates in it. Vaginal hydrocele, processus vaginalis remain patent only around testes, fluid gets accumulated and surrounds the testes. You may not be able to palpate the testes as it hides in the fluid. The upper limit discussed later will be reachable in case of vaginal hydrocele and incested hydrocele of the cord, while it may not be reachable for congenital and infantile hydrocele. This is the general review of the hernias in which we discuss the femoral hernias, the direct and indirect hernias, inguinal area pertaining to groins, what is midinguinal point and midpoint inguinal ligament, what are the relations and what is the anatomical figure. Now we will study the examination of inguinoscrotal area.